What if we told you that overcoming addiction isn't just about individual choices, that it's actually, profoundly shaped by systemic forces most people never even consider? Today, we're doing a deep dive into something really complex. We're looking at the often hidden ways racism and systemic bias influence addiction trends, treatment, and recovery outcomes for Black, Indigenous, and people of color, what we often call BIPOC communities.
Yeah, and our mission here is really to unpack the evidence. We've looked at a whole range of sources, scientific research, policy statements, even really powerful personal accounts. The goal is to reveal these unseen barriers, but also, importantly, to highlight concrete pathways toward more equitable and, frankly, more effective care for everyone.
Okay, so to start, let's maybe clarify what we mean by addiction, because it's not simply substance abuse, is it?
No, not at all. It's really understood now as a chronic brain disease. It impacts key areas of the brain, the ones controlling motivation, pleasure, memory. And, while we often think of substances, it can definitely extend to behavioral patterns, too.
Right, so the brain sort of gets rewired in a way. It struggles to function without that substance or behavior.
Precisely. And when we look at some of the initial data, the numbers really start to paint a picture of how addiction shows up differently across communities. These aren't just random figures. They're like a starting point for digging into these much deeper systemic issues we mentioned.
Okay, so give us some examples. What does the data show?
Well, for instance, within the Native American and Indigenous community, data suggests about 25% misuse illicit substances, around 10% suffer from a drug addiction, and 7% from alcoholism. And what's really notable there is that 4% are struggling with both addiction and a co-occurring mental health disorder.
That comorbidity is significant.
It is. Then you look at the Hispanic and Latino community. 19% misuse illicit drugs, 13% abuse both drugs and alcohol, and 12% suffer from either a drug or alcohol addiction. And among Asian Americans and Pacific Islanders, about 7.1% of adolescents, so that's ages 12 to 17, have tried alcohol. And close to 14% of all Asian Americans and Pacific Islanders aged 18 to 25 are estimated to need substance abuse treatment.
So these numbers, they're not just statistics to glance at. They're telling a story, aren't they? A story about these larger systemic forces at play. Okay, let's unpack this then. The idea that addiction trends aren't simply about individual choices, but are deeply shaped by environment, by life experiences.
Exactly. And these environments and experiences are disproportionately influenced by systemic racism. It's unavoidable when you look closely.
So how does that connection play out historically?
Well, what's fascinating and disturbing is how clearly history and policy illustrate this. You can look at the really dangerous and false narrative that emerged around crack cocaine back in the day. It basically stemmed from cultural or racial bias, and it wrongly linked criminal activity inherently to the communities affected, mostly Black communities. It sort of insinuated criminality even without the drug itself.
So a kind of double standard was created right there. You had one drug, cocaine, but in two forms, powder and crack, leading to totally different perceptions based on who was seen using which form.
Precisely. And this wasn't just like a vague perception. It got written directly into law.
How so?
This bias was literally codified in policies like the Anti-Drug Abuse Act of 1986. It created a shocking 100-to-1 sentencing disparity between crack cocaine and powder cocaine.
Wait, 100 times greater sentence for essentially the same drug?
Yes, 100-fold greater. Think about that. The same substance, different forms, leading to vastly different legal consequences, disproportionately affecting Black individuals. And this selective recognition of addiction as a medical issue is also really stark. For instance, federal funding targeting crack use in the 80s and 90s, which, again, primarily impacted BIPOC communities, was almost entirely focused on law enforcement, punitive measures.
Okay, so locking people up, not treating the addiction.
Right. Now, contrast that with the more recent opioid epidemic, which has been more closely associated with white individuals. Suddenly, 3/4 of the federal funding went towards research, treatment, and prevention.
Wow. It's like the system decided who was a criminal and who was a patient based largely on race, and then threw money or police at the problem accordingly.
That's a good way to put it. And media portrayals reinforce this divide constantly. You'd see depictions of Black and Hispanic people using heroin as criminals, inherently dangerous. But then white people using prescription opioids, often portrayed as sympathetic victims of circumstance, or maybe of doctors overprescribing.
And does this kind of neglect, this bias, continue today in policy?
We definitely see examples. Think about tobacco. In 2020, sales restrictions were put on many flavored tobacco products. But interestingly, menthol was often exempted.
And menthol is?
Menthol is the product most often used by black smokers, so the product favored by that community was left out of the restrictions in many cases.
Ah.
And another example, studies show significantly greater density of alcohol outlets, liquor stores, bars in Black and Hispanic or Latinx neighborhoods compared to white neighborhoods. Some researchers call this structural racism in the built environment. Basically, systemic inequalities are literally built into the physical spaces where people live, influencing everything from food access to, well, exposure to alcohol.
It's just so clear how these policies, these perceptions, they really laid a foundation of profound inequality. And that has real-world consequences for people's lives every single day.
Absolutely. And these systemic issues, they don't just stay abstract. They show up in very concrete ways in everyday treatment and legal experiences for BIPOC individuals. Take opioid use disorder or OUD treatment. The access disparities are quite remarkable.
So, what does that look like?
Well, data shows Black and Hispanic Latinx people are more likely to receive methadone. Now, methadone is effective, but it's typically only available in highly regulated clinic systems. It's sometimes described as liquid handcuffs.
Liquid handcuffs, what does that mean in practice? For someone trying to get well?
It means you often have to go to a specific clinic, usually daily, at specific times, just to get your dose. It's incredibly disruptive to work, to childcare, to just living a normal life. It's very restrictive.
Okay. And the alternative?
The alternative is often buprenorphine, sometimes known as Suboxone. White people are more likely to receive buprenorphine, which can be prescribed in a regular doctor's office setting. It offers much more flexibility, privacy, and, frankly, dignity.
So, same condition, OUD, but potentially a very different, much harder treatment path depending on your race.
That's what the data suggests. And then look at the criminal justice system. The statistics on drug-related arrests and incarceration are, frankly, shocking. Despite evidence showing that Black and white Americans sell and use drugs at similar rates, Black people in the U.S. are 2.7 times as likely to be arrested for drug-related offenses.
2.7 times.
And 6.5 times as likely as white people to actually be incarcerated for drug-related crimes.
Wow, 6.5 times. Even though usage rates are similar.
Exactly. And even within healthcare settings, clinician bias can play a role. Studies suggest clinicians are more likely to order drug tests for BIPOC patients. And if those tests come back positive, the consequences can be worse for BIPOC individuals if healthcare professionals disclose those results to outside entities, like employers or the legal system.
That just creates this cycle of suspicion and negative outcomes, and that immense toll from the criminal legal system, plus the everyday experience of racism that must ripple outwards, right, into family life.
It absolutely does. And a major way we see this is through stark racial inequities in Child Protective Services, or CPS, responses. Parental substance use is a frequent reason for referrals to child welfare, especially during pregnancy.
Okay.
But there's often this faulty assumption among healthcare providers, and sometimes others, that any substance use, even physician-prescribed medication-assisted treatment like methadone or buprenorphine, is automatically grounds for reporting to child welfare.
Even if it's part of their recovery treatment.
Yes. Even then sometimes. Which is why organizations like the American College of Obstetricians and Gynecologists, ACOG, they strongly oppose criminalizing substance use during pregnancy. They argue that laws requiring reporting force healthcare providers to act like law enforcement agents, which completely undermines the trust needed for good patient care.
That makes sense. It puts providers in an impossible position and could deter people from seeking help.
Exactly. And the impact is disproportionate. Although Black children make up about 14% of kids in the U.S., they represent 23% of children in the foster care system. They're also less likely to be reunified with their families compared to white children. And more Black infants than white infants are reported to child welfare due to parental substance use, despite, again, evidence showing comparable rates of substance use between Black and white individuals.
You know, as we were digging into the sources for this, what really struck me was how directly these external biases, these systemic issues, connect to individual mental health and well-being. It's not just theoretical.
No, it's very real. Think about the chronic stress of experiencing everyday racism. Things like being treated with less respect, being stopped by police for no apparent reason, being watched suspiciously in stores.
Yeah, that constant vigilance, that wear and tear.
Exactly. That causes immense stress. It takes a huge toll on both mental and physical health, and that stress can directly contribute to substance use behaviors as a coping mechanism.
And we see higher rates of certain mental health issues, too.
Yes, research shows Black populations struggle with anxiety, depression, and PTSD at markedly higher rates than white individuals. And relapse from substance use often has a strong correlation with these co-occurring mental health concerns.
Hmm.
And there was this really compelling study looking at Latinx heavy drinkers. Now, this group actually doesn't drink more than other groups. In fact, they tend to drink less overall than white people.
Okay, so they drink less,
But they're still more likely to suffer negative consequences, like death from liver cirrhosis or getting DUI citation.
yeah, would that be?
A significant driver identified in the study was a pervasive feeling of not belonging. This feeling was often worsened by shifts in the political climate, by experiences of exclusion and discrimination. In fact, a majority of the participants in that study, 20 out of 24, explicitly said they used alcohol to cope with those negative emotions stemming from feeling excluded.
That's powerful. Using substances to numb the pain of not belonging. And, what's even more crucial, perhaps, is this finding we came across.
Which one was that?
It showed that significant disparities in substance abuse treatment outcomes between Black and white people and between Latino and white people only really become clear after researchers control for other factors. Factors like Black people's higher rates of criminal history, which we know are influenced by biased policing, and both groups' lower socioeconomic status compared to white people.
Right. So what that suggests is that if you statistically remove the impact of poverty and the disproportionate criminal justice involvement,
Then the disparities in treatment effectiveness become even more obvious. It's almost like the system creates these disadvantages, poverty, criminal records, and then those disadvantages mask or even exacerbate the underlying inequities in the treatment system itself.
it's a complex interplay, but yes, that's a key insight. And the consequences of all these combined factors are literally deadly. Overdose death rates increased by a staggering 44% among Black people in 2020 alone.
44%, that's devastating. So bringing it back to the treatment itself, what does this all mean for actual accessibility and, maybe more importantly, completion rates for BIPOC communities?
Well, the national data isn't encouraging. It reveals that Black and Latinx Hispanic individuals were between 3.1% and 8.1% less likely to actually finish their treatment programs compared to their white counterparts.
Less likely to complete?
And Native Americans were 4.7% less likely to complete treatment specifically for alcohol use disorders.
Why do you think that is? What are the barriers to completion?
Well, part of it is historical context. Addiction recovery traditionally has largely featured white patients, especially those with good insurance and financial resources. That's just skewed the whole landscape, the diversity within treatment settings.
So representation matters.
It really does. Observations consistently show that, not looking like your treatment provider or not speaking the same primary language can just make that already difficult road to recovery feel even harder. It creates distance.
Yeah, I can see that.
And this brings us to a really critical issue. Cultural responsiveness, especially when we talk about sober living environments.
Right, the places people often go after initial treatment.
Exactly. Many sober living homes, particularly maybe the ones in more affluent or suburban areas, are predominantly designed around what you might call white middle-class norms. Even how spirituality or faith is presented, if it is, often comes through a very narrow cultural lens.
Okay, so what's the impact on residents of color?
It often leads Black and brown residents to feel like outsiders, like they don't quite fit. The unspoken message can feel like, yeah, you can stay here, but you have to assimilate. You have to fit into our mold.
And that's not just uncomfortable, you're saying it's actively harmful for recovery.
Yes, because recovery is so much about finding connection, support, a sense of belonging. If you feel like an outsider, like you constantly have to code switch or suppress parts of your identity, that creates another significant barrier. It hinders the healing process.
So it's not just about getting a bed, it's about finding a space where you can genuinely heal and belong.
Precisely. And this bias, this lack of cultural fit, it often originates even earlier, back at the treatment centers themselves. Many private centers cater primarily to, well, white middle-class clients who have insurance and savings. This can create what some sources call a validation loop.
A validation loop? What's that?
It's where resources, referrals, staff recruitment, everything tends to circulate within this predominantly white-centered system. So the well-funded private centers refer clients to sober homes that fit their model, and those homes thrive. Meanwhile, community-based recovery supports that are perhaps more rooted in communities of color, they often struggle for resources and referrals. They're outside that main loop.
Okay. So the system kind of reinforces itself.
It can, yes. And there's another related finding. Research shows that people who choose sober living primarily because they have no other options, maybe it's court-ordered or they lack family support, tend to experience more psychiatric issues during their stay. It suggests that lacking genuine choice and a sense of agency, feeling forced into a setting that might not be the right fit, can hinder true healing.
It just really underscores how critical it is for addiction care and recovery housing to be culturally responsive. Not colorblind, but actively reflecting the communities they serve.
Yes, in staff, in leadership, in the actual programming, it's about creating environments where people can not only recover, but truly feel like they belong.
So, if we try to connect all these dots, pull it together into the bigger picture, what do the sources suggest as solutions? What are the actionable recommendations for change?
Well, there's a pretty comprehensive set of recommendations aimed at advancing racial justice, both within addiction medicine specifically and in broader society. For healthcare professionals and practices, the main call is to really examine their own biases, conscious and unconscious. The goal is delivering care that's equitable, compassionate, and actively informed by anti-racism principles.
Okay, so it starts with individual awareness for doctors, nurses, therapists. But how does that translate into practice? It can't just be theory, right?
Right. It means actively acknowledging and responding to patients' experiences of racism. Using trauma-informed care approaches is key. It also means routinely assessing for social determinants of health, things like housing insecurity, food access, transportation, and actively connecting patients with community resources that can help address those needs.
So, looking beyond just the symptoms of addiction to the person's whole life context?
Exactly. And part of that is developing what's called structural competency. That basically means healthcare providers need to understand how these larger structural factors, inequalities in law enforcement, housing, education, healthcare, access itself, how those things shape their patients' health and experiences.
That makes a lot of sense. Treating the person within their actual environment. What about changes needed at the higher level within healthcare systems and institutions?
Yeah, the recommendations there focus on several key areas. One is increasing workforce diversity at all levels. Representation matters hugely. Another is expanding the range of evidence-based services offered, making things like buprenorphine and the overdose reversal drug naloxone much more widely available, not just in specialty clinics, but maybe in emergency departments, primary care, even community settings.
So, meeting people where they are.
Yes. And addressing those social determinants of health through practical measures like open access scheduling, making it easier to get appointments, offering mobile services, expanding telehealth, and building strong partnerships with local community-based organizations that have trust within specific communities. And fundamentally, all healthcare systems should really assess their own internal guidelines and policies through a health equity and racial justice lens. Are our rules accidentally creating barriers?
That seems crucial. And what about the research side of things? How can research contribute positively?
Addiction-related research needs to make a conscious effort toward equitable representation. That means including BIPOC researchers in leadership roles and ensuring diverse participant pools in studies. Research also needs to specifically evaluate the impact of systemic racism itself on drug use patterns and on access to prevention and treatment. We need data on the problem to fix the problem.
Okay, so that covers the healthcare and research realms.
Mhm.
Moving beyond that, what are the broader policy shifts being recommended? These seem aimed at those bigger structural issues.
Absolutely. For policymakers, a core recommendation is to fundamentally shift the nation's approach to personal substance use away from criminal justice framework and towards a public health and wellness framework.
So, treating addiction as a health issue, not primarily a crime, what would that look like in practice?
It would mean things like eliminating criminal penalties and also overly burdensome civil penalties for personal drug possession and possession of paraphernalia like syringes.
And would that involve addressing past harms from the criminal justice approach?
Ideally, yes. Recommendations include considering the expungement of criminal records for nonviolent drug offenses, which disproportionately burden BIPOC individuals, and actively prioritizing the elimination of over-policing in these communities.
Makes sense.
There's also strong support for new clemency efforts for people currently incarcerated for nonviolent drug offenses again, many of whom are BIPOC, and, crucially, passing federal legislation to finally eliminate that crack versus powder cocaine sentencing disparity and making that change retroactive.
Righting that historical wrong. Beyond the legal system itself, how can policy address those root causes, those social determinants of addiction we talked about?
Yeah, this is critical. Policymakers should look at eliminating drug conviction bans and, in many cases, drug testing requirements for essential public assistance programs. Things like SNAP, the Food Assistance Program, and TNF, which provides temporary financial assistance.
Because denying basic needs makes recovery harder, not easier.
Exactly. Same goes for financial aid for education. And ending evictions and bans from public or subsidized housing based solely on nonviolent drug-related activities. Stable housing is fundamental for recovery.
Absolutely. And what about healthcare access itself?
The big call there is for implementing universal healthcare coverage. That's seen as essential to support equitable access to evidence-based addiction care for absolutely everyone. And alongside that, vigorously enforcing the existing mental health and addiction parity laws, making sure insurance actually covers addiction treatment adequately, just like it covers, say, diabetes or heart disease.
It sounds like these recommendations, taken together, really offer a tangible path forward, a blueprint for redesigning the system to center dignity, structure, maybe even faith in diverse ways, and that crucial sense of cultural belonging for everyone trying to recover. So today we've taken a really deep dive into this powerful and I think often overlooked intersection of systemic racism, bias, and addiction. We've seen how policies, perceptions, and everyday practices can create these deep, deep inequities. But importantly, we've also uncovered some powerful recommendations for change for building a better system. Which leaves us with a final thought for you to ponder. If addiction is truly a chronic brain disease, as the science tells us, and if systemic racism acts as this kind of chronic, pervasive stressor that disproportionately harms health and blocks access to effective treatment, then what is our collective responsibility? Is it just to heal individuals from addiction? Or is it also to heal the very systems that make certain communities so much more vulnerable to it in the first place? We really encourage you to consider how these insights might challenge your own understanding of addiction and justice. And maybe think about what role you, as a well-informed individual, might play in advocating for a more equitable, a more compassionate